Right, once again, good evening. If you can write yes in the chat, if you can hear me and see me clearly, please, that would be great. Thank you. Right, thank you for the yeses. Excellent. Thank you. Okay. Okay, so looks like most of you can see me. All right. Okay. Right. Hope nobody's stuck in the waiting room. Okay, so today we're going to talk about late life sleep, insomnia, and interventions. You realize that this course isn't a course on interventions. In fact, the assignment is not even an intervention assignment or intervention project, as I have said several times. So this is probably the one of the two sessions or lectures that you would see and hopefully experience some intervention. Last week, I did introduce the intervention called the cognitive behavioral mind restructuring, so to speak. Sorry, cognitive restructuring, right? So went through with you regarding mood disorders and how those could be treated, right? If you recall what the gold standard was, and then as part of that gold standard, where psychological therapy lie, right? That is the knowledge that this course hopes to impart. Not so much how to do interventions, but what are effective interventions and what are the main ingredients on which they work. So today, as you have seen in the lecture slides, there are two or three interventions that we could discuss today with regards to sleep problems. And you will realize that many of these interventions, while they could be tailored to older persons, right, they're not necessarily exclusively used in the treatment of age-related or old age-related conditions. Okay, I have now just shared the PowerPoint slide. It says participants can now see my application. I hope you could see the full screen PowerPoint presentation. Right. Okay. Is there anyone here who is kind of keeps getting kicked out of the room or keeps getting stuck in the waiting room? If that is you, you should let me know. Right. If not, we should begin. And I hope that we can do a little bit of a demo and get you to also break out into breakout groups later on, because as I will introduce you later, this clinical evidence-based scientific mindfulness meditation and the various forms of that could really be self-taught, self-induced, and could be called many names, and that there are many ways to practice them. Okay, so here's the outline. We talk about what normal late life sleep looks like, and then we talk about the prevalence and incidence of late life sleep disorders in Singapore, followed by the potential causes and risk factors of late life insomnia, and then we move into the interventions. What is normal late life sleep? Well, normal late life sleep is essentially less deep sleep and more light sleep, right? So that is essentially less stage 3 and more stages 1 and 2. So men more than women, right, experiences this among older adults, right? And in fact, before 60-year-old, there is already evidence that shows that this phenomenon begins. As much as any healthy adult individual will go through the usual 4 stages and then the rapid eye movement, right? That we see in persons kind of coming near to 60 years. Among these people, that it starts to be a decline in the stage 3 and an increase in stages 1 and 2. Right. Of course, then you will ask me, is that reason why older persons wake up very frequently at night, well, that remains to be seen. But waking up frequently for whatever reason, right, may be understood as interrupted sleep today, which is one of the 3 types of insomnia. Older persons also experience longer time to fall asleep, increase in awakening, and difficulty resuming sleep. Why is that so? Right, we do not yet have clear evidence, and this phenomena, right, these 3 types of phenomena, essentially 3 types of insomnia, right, which older persons may undergo. So when we say this is normal late life sleep, we say that, look, kind of after 90 years old, when one realizes that he or she takes longer than previously to fall asleep, that is normal. That is normal, right? However, if a person before that age or before 80 experiences a dramatic increase in the amount of time taken to fall asleep, then we could say that might be insomnia. That person should see a doctor and be referred further if necessary. So the reasons for these are unclear. The reasons for both the first and second bullet point are unclear at this moment. There are arguments for biopsychosocial mechanisms at work. There are also arguments for age-related changes in the neurobiological substrates, such as growth hormones and serotonin. Okay, how prevalent is sleep problems, right? So insomnia essentially is a complaint of one or more of these symptoms: difficulty in getting into sleep, difficulty in maintaining a healthy or desirable length of sleep, waking up earlier than one would like to, and waking up feeling like I haven't slept, just as if I have just wasted 8 or 7 hours on the bed. Right, so that's insomnia. Right, insomnia is often accompanied by daytime functioning impairments. Right, and you can think about many of those functional abilities that one has, which are used in the day. They occur in the context of sufficient opportunity to get the desired amount of sleep. That means to say that, look, you have every opportunity to sleep for, say, a certain duration of time, non-interrupted, right? However, because of one of those 4 complaints, one or more of those 4 complaints, right, one might find that, in the day one couldn't concentrate to do his work. One makes some silly mistakes, like copy and paste large chunks of text, let's say, to other things like walking and tripping over, right, and so on, right? So we're talking about various kind of cognitive, ambulatory, perhaps even dexterity kind of functional impairments. The DSM-5 and the ICSD-2 are 2 diagnostic manuals to diagnose insomnia. Right, so DSM-5, you know what that is, right? There is criteria for diagnosis. The ICSD-2, right, there's another criteria for diagnosis. They overlap about 80%. They define insomnia similarly. Okay. Beg your pardon. All right. There should be a box. Okay. I'd like to draw your attention to this part here. Right. So this table 22.1 shows 1, 2, 3, 4, 5 studies that cite the prevalence of insomnia, right, in older adults. Right. After the year 2000, these studies were published in the various countries, as you can see there. They studied people 60 or 65 and above, right, and reported on the prevalence estimate in those populations. Right, so you could see Italy, prevalence 44.2, and so on. Nigeria, France seems to have lower or lowest among the 5 when it comes to insomnia complaints. Right. Now, in the US, right, it seems like that there is age band differences and gender differences. 60 to 69-year-old have a different prevalence than 70 to 79, than 80 to 89, right? With the lower age band experiencing less, reporting less insomnia symptoms and complaints, and there seems to also be a gender difference or sex difference, right? Where you see that women more than men reported insomnia symptoms in the US. Now, how about the numbers in Singapore regarding sleep disorders or insomnia? Right? A study published in 2017 found that about 13.7 or 14%, right, of older adults reported at least one sleep problems, at least one of these three sleep problems, right? Of these 341 older adults, 69.4% had sleep interruption, close to half have difficulty falling asleep. About say 1 in 5 had early morning awakening, wake up too early, and about 10% or 1 in 10 had all three problems. Now we move on to the potential causes and risk factors, right? Theories that help us understand these risk factors and causes of late life sleep problems. Right. One way to understand late life sleep problems, as with many other biopsychosocial phenomenon, right, is to take a triple P approach: the predisposing, precipitating, and perpetuating groups of factors. So we say this is the development kind of approach to understanding, or development kind of theory to understanding insomnia. Right? The development of insomnia has been understood or conceptualized as a progression from pre-illness or pre-morbid to predisposing state to the experience of an acute, or you can say discrete event, a precipitating event that induces transient, a short period of sleep disruption. That is the stressful event there. And then in response, the adoption of behaviors and thoughts or cognitions that are often intended to compensate for poor sleep, but often result in the perpetuation or the aggravation of sleep problems, right? So issues like impaired plasticity, personality, personal history, hyperarousal have been associated in a somewhat longer term fashion with sleep problems, but not necessarily function as trigger, right? So there often is one kind of stressful or triggering event, right? It could be anything. It could be getting a phone call at night, unexpected, or it could be something dropped. It could be in the night while one is asleep, or it could be just hearing the clock tick, in the room, or feeling hungry or feeling full, or thinking about worrying thoughts, or looking forward to something that will happen the next day in the mind. Any of these, right, could potentially be a trigger, that stressful event. And then when one realizes that one couldn't say sleep, or have poor sleep, or have woken up and couldn't fall back asleep and so on, then one does a series of different things, or think a series of different thoughts that unfortunately, instead of compensating for that poor sleep or lack of sleep or interrupted sleep, actually aggravates, right? So you can think of for yourself what are some of the things you do. Perhaps you look at the clock. Perhaps you say go back to the toilet again a second time, hoping that you do not need to go again in the next few hours, let's say. So perpetuating factors are behaviors and cognitions that in the short term appear to be logical solutions, right, to eliminating sleep disruptions. Some people, sleep for say 10 minutes more, another 10 minutes more, right? I don't know if you can experience that in the mornings, especially. How about half an hour more? Hit the snooze button, say twice, 3 times, and so on, right? and then to extending time in bed, napping in the middle of the day, perhaps consuming sedative substances or sedating substances, right? Or stimulating substances in the day when one is awake, in order to eliminate sleep disruption, right? I don't know if any of you have tried any of these, in the hope that your sleep problems may diminish or go away. Often research has found that they don't. In fact, engaging in such behaviors in general, on average, does tend to worsen the sleep issue. So over the long term, these behaviors and cognitions can create greater sleep pattern variability or fluctuation, right? A non-sleep promoting environment, poor sleep hygiene, you must have heard of that word, and unrealistic expectations of the sleep experience, right, could be a result of these various compensating thoughts and behaviors. So collectively, these thoughts and behaviors could perpetuate the sleep disruption beyond the duration and or intensity of the originating or original precipitating event, the trigger. Some major theories. Right. One of these theories is called the HyperArousal Hypothesis. Right, which essentially investigates the emotional and the physiological mechanisms involved in sleep disruptions. So this theory describes insomnia as a 24-hour psychobiological disorder. Right, so you have the emotional arousal system, you have the central nervous arousal system, and then you have insomnia. That's the idea, that the stressful events and the fear of sleeplessness or sleep problems, right, gives rise to the arousal of the emotions, and of course depression, anxiety, and the various physical / mental, you can say, illnesses or symptoms. All this gives rise to emotional arousal. This emotional arousal may lead to central nervous system, or what we call physiological arousal, right? Or it may lead to, right, or it may be caused by central nervous system or physiological arousal. So you don't see an arrow from emotional to CNS or the other way around. So it really could go both ways, really, right? So with CNS contributions, you could see there those contributors, right? Normal sleep changes, stimulants, so on and so forth. Both emotional arousal and CNS arousal then interact to give rise to sleep problems. That's essentially the basic idea of this hyperarousal hypothesis. The etiology is associated with alterations in the neurobiological substrates and psychosocial stress, and maladaptive behaviors and cognitions that I mentioned earlier that tend to perpetuate rather than remedy the sleep problem. Evidence supports this hypothesis among younger adults, but among older adults, unfortunately, we do not yet have strong evidence. Right? So this is one theory that might be used to try to understand sleep problems among older adults, but yet at the moment we do not have enough research that supports this among older adults. Okay. What are the risk factors? 1, 2, 3, 4, 5 main categories. They are stated in your text, right? Acute stressor, I think I said that already. Many things, in fact, almost anything could be an acute stressor, really. But the known ones, right, would be traumatic events, acute traumatic events, acute stressful events, and that could be of a work nature, a health nature, a social nature, and so forth, right? And then another risk factor is what we call the circadian rhythm issue, right? People who work in shifts, right? Security guards, our frontline service men and women, essentially, right? often work shifts, our healthcare workers, for instance, right? Their body clock, essentially, it's different from ours, right? So they may develop symptoms of circadian rhythm disorder, and that one or more of these symptoms may be directly or indirectly linked to sleep problems. And then we have the medical / neurologic condition, right? People who are on medications for a neurological condition, who are on substances like caffeine, alcohol, right? Or who use hypnotic dependent, hypnotics, right? Substances, right? Like hypnotics, right? May experience sleep problems. A psychiatric disorder, number 4, such as mood, depression, bipolar, anxiety, panic attacks, panic disorder, phobias, agoraphobia, obsessive compulsive disorders, and so on, right? These are also associated with old age sleep problems. And then finally, right, there's some emerging literature to suggest that old age sleep problems kind of is associated with social support, lifestyle, and financial status, such that when there's low support, unhealthy lifestyle, and problems in one's own finances, right, those kind of tend to be associated with greater intensity or duration or frequency of sleep problems among older adults. Probably those are not direct links. Probably there are other mechanisms involved, and probably those are what we understand as disparities in healthcare among older adults, or disparity in healthcare in general, so to speak, right, among recipients of healthcare. But certainly, if we can understand risk factors simply, right, among the 5, the last one there is probably easiest to understand, right? Socioeconomic status. And then to make changes, well, perhaps if it's at a population level, public health level, at the societal level, perhaps, right, the one at the bottom, the 5th one, is something that public health systems look at. Although those 4 up there tend to be a bit more specific to an individual's domain, like individual's health, social, mental health, and so on. Right. Here we see a study that reports the relationship between sleep problems and physical activities, chronic physical condition, and chronic mental conditions. Right. Odds ratio, as you know, report on likelihood of something happening. The greater the odds ratio, the more likely something will occur. Right. The greater the likelihood, the higher or the stronger association between 2 variables. Right. So here we see that chronic conditions like depression, heart problems, those in red box, right? Persistent cough, asthma, stomach or intestine problems, probably irritable bowel syndromes as well, faints or blackouts, paralysis, right? And those who experience pain, who undergoes physical activity, right? That you see these things significantly, statistically associated with sleep problems. So we see that presence of sleep problems was a predictor variable in all regression analysis. So this was a logistic regression. You see 1.9, right? That is 1.9 times more likely than the comparison group. So persons who were depressed, for instance, were close to twice as likely, close to 2.0, so 2 times or twice as likely as persons who are not depressed, right, to experience sleep problems among older adults. Right. So we look for the biggest number there. What is that? Persistent cough. Right. I believe many of us could relate to that, right? How many of us actually, wakes up and you find yourself first of all coughing, right? Or how many of us, when we cough, we just cannot sleep, cannot fall asleep? In fact, that might beg the question of how many of us actually experience poor sleep when we have an itchy throat on that night, just on that day or that night itself. So we see here, right, 3.0. So 3 times as high as the likelihood of not having cough right? That's the strength of a persistent cough when it comes to its association with sleep problems. Okay, there is another one there, pain, 3.2. So that's more than 3 times as compared to persons who do not report pain. Interventions. Pharmacological intervention is one type, as you know. If psychological treatments are unsuccessful, or if the insomnia is in its acute phase, often hypnotics should be considered in the short term. So hypnotics is actually sleeping pills, and you have those 3 types of sleeping pills listed there, right? Unfortunately, hypnotics, i.e. sleeping pills, have side effects. Impaired cognitive functioning, daytime sleepiness, which is usually related to the increased risk of falling down, and kind of sleepwalking or parasomnia-like symptoms. So hypnotics should be used not forever, it should be used only to manage the acute symptoms, and other therapies should follow when it's appropriate. Psychological therapy, essentially. The gold standard for psychological therapy that is often used to wean off hypnotics and to continue treatment for the affected individual for a longer term is usually what we call multifaceted in nature, or multi-component. Right? Same idea, right? It's called multi-component in the last lecture in mood disorders. Here researchers call it multifaceted. The idea is the same. Essentially, the idea is that the psychological treatment or therapy should take care of the cognitive aspect of sleep that causes a person to lose sleep, should take care of the behavioral aspect of sleep that causes a person to lose sleep or to have poor sleep, right, and other aspects as well. So older adults with insomnia have shown significant improvement in their sleep problem symptoms, right, with the use of CBTI. So that's one type of psychological therapy called the cognitive behavior therapy for insomnia, right? So it is increasingly CBTI is becoming a first-line treatment for chronic insomnia, above and beyond that of pharmacological interventions, right? Think back to the causes, the etiology, the risk factors for late life sleep, right? Flip back to the slides earlier, right? You'll find that there is a multi-domain observation there, right? So recall SES, right at the bottom. Recall mental disorders or psychiatric disorders, then other health problems. So we see that because risk factors are multifaceted, this is why the psychological therapy needs to take multifaceted approach or multidisciplinary approach. So there are many other cognitive and behavioral treatments. So CBT is one of them, right? Psychoeducation on sleep, that's another. Relaxation therapy, sleep hygiene training, stimulus control, cognitive therapy without behavioral component, or behavioral therapy without cognitive component, sleep restriction, many of these. In fact, all of these have demonstrated efficacy. That means success, right? However, if it's not automatic, right? Intuitively automatic that if you combine all these, you have greater success. But the cognitive behavioral therapists manage to achieve measurable success for the use of CBTI for insomnia. So I can read another piece of research here. CBTI has demonstrated substantial treatment efficacy across many trials for both primary and comorbid insomnia, right? On outcomes of insomnia symptoms, as well as daytime and mood-related symptoms. Approximately 70 to 80% of patients exhibit improvements in sleep post-treatment, post-CBTI treatment. And older adults with insomnia also have shown significant improvement in their sleep symptoms with CBTI. Okay, we go down a bit more and to understand what are the various components or facets of CBTI. We have the sleep hygiene component, right? That essentially is, you can see the 5 items there: caffeine use, alcohol, tobacco, food, exercise, right? Essentially, it's to discuss lifestyle and moderate lifestyle activities of the patient. Stimulus control, right? So it's often about the environment around that person's body, or somewhere immediately near his or her body, right? Lie down only when you go to sleep, right? There's often one prescription or advice. Do not use the bed for anything other than sleep and sex. If you cannot fall asleep within 10 minutes, get up, go to some other room, and so on. We call this stimulus control. Sleep compression or restriction techniques aims to match the patient's time spent in bed to their actual time spent sleeping. So if one lies in bed and do not sleep, then one might actually be conditioned or learn, right? Learn that, well, bed is for something else, say playing of a game or watching a video, right? Many of us bring our phones, perhaps even our tablets, our computers, laptop computers to bed, right? So if one could be prescribed bed and wake times that is very close to actual sleep time, and so do not give oneself a lot more leeway to go into sleep, to fall asleep, and a lot more leeway post-sleep, after sleep. One could actually just restrict oneself and one's bed to just for sleep only, right? So then that's the idea of sleep restriction. Sleep time is meant for sleep only, nothing else. You can do everything else at other times. Relaxation. Okay, you must have heard of many of these techniques: diaphragmatic breathing, biofeedback, and so on, imagery, right? The challenge, of course, is in today's fast-paced society is time. It's actually time, putting oneself, giving enough, well, I won't say even enough time, putting high enough priority to actually engage in one or more of these relaxation techniques, right? Progressive muscle relaxation, deep breathing, or what we call diaphragmatic breathing, right? And so muscle relaxation techniques, right? And then there's the cognitive therapy that focuses on identifying maladaptive beliefs about sleep and replacing or restructuring these maladaptive beliefs or thoughts to something more adaptive. Very similar to what we learned last week on thought challenge. If you recall, we talked about describe the situation, what are the thoughts regarding the situation, how do these thoughts make you feel, what if these were there other alternatives, or were there other evidence that suggests your thought is true, right? Then now with these other evidence, how will you now go back to verify the veracity or the validity of these thoughts related to or regarding that situation? So the situation is some sleep problem related situation. That's cognitive therapy, which if you want to really learn, you should take a postgraduate course in professional psychology and not one that is in research psychology. Then there is hypnosis, right? In the past, you must have heard about people under hypnosis or in a trance-like state being asked to do funny things and make a fool of themselves, or could even be subjected to danger or risk, right? Now that you have studied HP 1000 and other psychology courses, you must have come to this understanding now that hypnosis is pretty much used in settings for treatment and or to better performance, to improve or enhance performance, right? So the medical use of hypnosis, people call that medical hypnosis, right? The the use of hypnosis in other settings, right? Let's say performance boosting or enhancement, right, will be called something different, but the underlying active ingredient is identical, right? So we can say that even laypersons, aside from doctors and psychologists and therapists, could perform hypnosis, and hypnosis has also been found, right, to be able to be induced by oneself or on oneself. part of the mechanism of hypnosis deals with new cognitive behavioral mechanisms. The other mechanism is what we call the neurological mechanism. Now, hypnosis is used on a variety of stress-related behavior, psychiatric and chronic conditions. I mean, the some of the more known effects of hypnosis would be pain control, right? Relaxation inducing and sleep improvement. These are essentially the three known benefits of hypnosis. Persons who were under surgery, right? The well-known type of surgery would be the hand and leg, what we call MSK, musculoskeletal kind of surgery, right? Who would usually otherwise require GA, general anesthesia, or LA, right? Who could, if he or she is a seasoned or trained practitioner of hypnosis, right, could actually not require the anesthesia when he or she is put under, or is under the influence of, or is in a trance-like state, with or without the presence of his or her therapist or hypnotic therapist, so to speak. So it has moved, hypnosis has moved, at least medically, from an adjunctive or supplementary or complementary treatment to the first-line treatment. In one of my previous workshops, I asked workshop participants, and there weren't many participants. I think there were only like maybe 8 or 9 of them. I asked them first, do you experience any of the following situations lately? Sleep problems, financial stress, work stress, and these are the distribution. You can see work stress, right? 5 among, I think, 8 or 9 of them, and then headaches, right? Then, before I taught them some relaxation techniques, I asked them, have you ever experienced the following situations? Insomnia, feelings of anxiety, loss of appetite. So we find that, right? Anxiety, stress, and insomnia, 3. I do not know if if there were repeat counts or double counting, so to speak, right? But these are typical instances where one would be very receptive, right? Very welcoming, forthcoming, right, to the learning of techniques to deal with stress or to reduce stress, right? Well, I don't think I can do this with you here. In class, physically, I actually get everybody to stand up and to do this exercise. There is some HP 1000 would have taught you about the origins of mindfulness, right? Mindfulness techniques, right? And yes, you would find that you will see traces of Buddhism, and if you date back further, certain sects of Buddhism, right? It is really this Kabat-Zinn's work, right? So professor of medicine called John Kabat-Zinn in 1979, right, developed a secular form of meditation or mindfulness practice, right, that he calls mindfulness-based stress reduction, or MBSR, an evidence-based practice, right? He took the teachings of Buddhism and merged them with modern medicine, right? Took away all these the rites, the chants, and so on, right? And developed techniques, right? In 1979, then thereafter, there are other persons who furthered his work. Now, in mindfulness practice, it was thought that we need a quiet environment. We need to have very a peaceful mind, so to speak, right, and so on, right? Turns out that according to the Benson Henry Mind-Body Institute at Harvard Medical School, only a single-minded focus and a distracted attitude, right? Only a single-minded focus and a distracted attitude is necessary, right, for mindfulness to work. So even if one is in by the side of a crowded within a crowded place, or by the side of the road, crowded road, a lot of traffic, right? Or if one is alone by the beach, hearing the sounds of the sea waves, the waves coming in and going out, regardless, right, one could practice mindfulness. So Harvard Medical School did various research, and essentially what they found was, now I need you to type the answer in the chat. How long do you think one really lasts? What one really takes to enter into a state of mindfulness or hypnosis, right? From the beginning. Type in the chat in the next 6 seconds or so. 1, 2, 3, 4, 5, 6. Thank you very much. Let's see. 10 minutes, 5 minutes, a few minutes, 2 minutes, 5 minutes. Okay, what do I have? 10 minutes, 3 minutes, 5 seconds, 3 minutes, 24 minutes, 10 seconds, right? Okay, I think Jonathan got the closest. The answer is 17 seconds, right? So the seasoned practitioner could go into a state of mindful state in as soon as 17 seconds. That's what they found, right? And this person doesn't have to be a Buddhist. In fact, may have zero Buddhist understanding of Buddhism, so to speak, right? So yes, they of course in the past also did the research with initially they did research with Buddhist monks, right? So they essentially what do you call that? Ask these Buddhist monks to come into some room before they started doing their Buddhist meditation. Hook them up onto the various monitors, right? Biofeedback, right? ECG, wear that cap with all the electrodes, right? Blood pressure and all those things on the body, right? Okay, and then measure the baseline, right? And then these monks were asked one by one individually to begin their meditation sequence and so on. And so the scientists tracked those biofeedback, right? So one who is in a more stressful or awake state tend to have some level of activity in the various, but all these activities should kind of fall or go lower. Like one's skin conductance should drop, temperature should be lower, rate of speech should be slower, and heart rate should be lower, blood pressure should be lower, especially the what do you call that, the systolic, right, and so on. So they found that, well, among this small number of monks, there were at least 1 or 2 who could in fact get into a trance-like state in as soon as 17 seconds. It's almost like before the scientist realizes it, these charts were at a low trough, low baseline, and the monk is still actually awake, right, doing his chant. So then they repeated this experiment, or this randomized, not so random, this controlled trial, so to speak, on another group of people, this time non-Buddhists, right? So these people were taught some of these techniques of MBSR, mindfulness-based stress reduction, right? And then they measured, and they realized, yes, these secular people, non-Buddhist people, were able to get themselves their various biofeedback monitors to show a decline in the various indicators, right? But because they are not so well trained, right, in mindfulness, the decline took longer. So then they got these people to train, right, to learn, to what you call do self-induction, to read and memorize scripts that one could bring oneself into a guided right, into a state of hypnosis, so to speak. And then remarkable results shown, right? Less than 30 seconds, many of these people, right, after a good duration of training, was able to go into a very relaxed state. So today you see me using the terms mindfulness, guided imagery, hypnotic state, induced state, altered state of consciousness. Many of these terms do not yet have distinct boundaries at the moment. So I should say that more research needs to be done to kind of separate them. However, the techniques used, right, do have different names. Mindfulness meditation, some techniques. Guided imagery is techniques are at least verbally different from, say, self-hypnosis techniques. Right? Although the underlying mechanism may most likely be very, very similar or identical, research is yet to show that to prove that in a very quantitative way, so to speak. So, where are we? Okay, so once again, mindfulness essentially works two ingredients. Hang on. Before I get everyone to do this, I realized I shared a different deck of slides. Give me a moment. So what I like us to do is this. If you can take this time now to go to NTU Learn, right? Go to NTU Learn and go to the content section, right? Under week 12, supplementary readings, you will see a 3-minute script. I'd like you to download that and open that up on your computer or on your phone, right? Let me open that. This is how it looks like. Let me know when you are there. I'll do a quick screen share just so you know what it looks like. Okay, so this is how it looks like. Right, okay on the chat to let me know you have found this, and I will stop the screen share and give further instructions. Right, okay, good, thank you. I see so many okays, excellent. Right, anybody who cannot find it, it's in the supplementary readings. Okay, good. So this is a script that I encourage people, well, that I suggest to different persons I train, right, to kind of learn mindfulness, to use it for themselves. And possibly the best way to do that is to learn it with one other person first, because that one other person could read the script to you while you, being the meditator, could close your eyes or don't close, right, whichever that is comfortable, right, and kind of just follow the suggestions and follow the verbal, you can say, instructions given by the other person, right? And that's probably the best way to kind of learn first by experiencing it. Then, right, you could then do it for the other person, switch role, and then you read it. So at this time, when you now read it, you kind of realize, okay, what is being read and what is the nature of the kind of instructions. And it is really not long and complicated. It's only a page, less than that, right? It takes 3 minutes to do that because you will read slowly with somewhat moderate pace and not so loud and powerful voice and so on, right? But audible, clear enough. So that is something that often I use. And then when we have the privilege of a third or a fourth person, then the fourth or third person could actually visually monitor, observe, right, both the reader as well as the meditator, right? The reader's speed of voice, tone, volume, and so on. The meditator's physical, i.e. facial and bodily indicators, any signs of relaxation, right? So that is something that observers could do, and then they could exchange notes to find out what worked and what didn't work for them, especially if these are novices, people who are new to meditation, new to mindfulness meditation, or even the concept of mindfulness, right? This often works to introduce them, right, into by exposure, by limited experience, and by peer coaching. What I haven't done beyond HP beyond HP 3303 is to do this online. I think we tried to do that in the last semester, and there was quite a bit of excitement among the students. We did it. I actually, in fact, had more students than this, right? But it was at a different time of the day, and it was in the afternoon. Now we are 7:30, so I'm not so sure, right, how the experience might be for you. But let me give you the instructions now for us to practice in our groups. Let me take out the instruction slides. Okay, instruction slides are here. Okay, let's share this. Share screen. Okay, I believe you could see my slide right now. 3-minute body scan mindfulness meditation. In a short time, we'll break into groups. I'd like us to have at least 3 persons in a group or more. The reader takes a reading role, reads slowly with regulated tone, right? Have an observer to observe the reader, and if you have 4 persons, you have a second observer to observe the meditator. If not, then the observer will observe both, right? And so obviously that means your microphone feed should be turned on, your video feed should be turned on, right? And then we have a meditator, right, or meditators, right, who would simply follow the suggestions of the reader, right, for that 3 minutes or so, right? And well, after that you could kind of change roles and so on. So let's give, say, maybe 2 or 3 rotations for about 15 minutes, for maybe about 10 minutes, let's say, for everybody to do this, right? So once again, note the instructions here. We have the role of a reader, the role of an observer, and the role of a meditator, right? Let's see if any questions before I split you all into your breakout rooms. Oh, to facilitate that, be good if you could put your team number next to your name on Zoom. Okay, instructions are done. I will stop share right now. Okay, and okay, I'm just waiting for some team numbers to be there. So yep. So RX is 9. Ansheng team number. Ben, we need team numbers. Yep. And then we could go into our breakout rooms quite quickly. Let's see. We may not have enough people, right? There are 3. Yeah. Let's see. We probably have to combine some groups if your members aren't here. Okay. So I'm gonna create the breakout rooms right now. Right. So after, so I'll give you about 10 minutes to do this in your groups, and then when we reconvene, I'll ask each group to have just 1 person, right, to share the experience, right? That person might have done 1 or more roles, meditator or observer or the reader. That's fine, right? So I'm going to create the breakout rooms and put different people in those rooms. So as soon as you're in those rooms, you could practice that, right? And I'll come along to your rooms, right? Okay, so you can get ready to turn on your feeds accordingly. I should ask you to note that you probably want your camera, right, to be at some distance from your body, so the other person or persons could see you and see your face, like what I'm doing right now. So my camera is right here. You can see kind of my upper body. If I do deep breathing and so on and so forth, right, the person could see. Okay, so I'm gonna get people into the groups right now. Room 2, room 1, room 3, Room 3. Oh, I do not see any group 3 people here. Group 4, Cheryl. Okay, Cheryl, and I do not know who else is here. Group 5, I don't see any group 5 people here. Is there anyone from group 5 here?
Yes, Prof.
Group 5? Anyone? Ben?
Hello, Prof. Yeah.
Oh, that's you. It's just you. Okay. All right. Okay. Let me assign other persons who have 2 or more in the group first. Then I'll assign Ben. So group 7, we have 3 of us. Group 8, we have 1, 2, 3 of us. Group 9, 2 of us. And in fact, 3 of us. Group 10, seems like there's only one. Group 11, 1, 2 of us. And then group 12, we have 3 of us. About it. I think we could open the rooms right now. Okay. And then those who are not assigned, I will try to assign you accordingly. So Daphne are not assigned. I'll put you in the room 1. John, I'll put you in room 2. And Tahira, which room, which group do you belong to? And Ben, you belong to group 5, right? I think
Yes.
Ben, I'll put you in room 4 with Cheryl. She's the only person in that room.
Okay.
Practice that. Okay, here you go. And Tahira, are you here, Tahira? Which group do you belong to? Hi, Alexis. Yes.
Hi, if you don't mind, can I join my friends in group 1? Because my group also not here today.
Oh, yeah, I just realized. Sure, group 1, that's okay.
Okay,
Put you
thank
in group
you.
1 right now. Okay. All right. And Tahira, are you here, Tahira? Okay, so Alexis, you can feel free to move to group 1, room 1.
I don't think I can because I've been assigned to room 10.
Room 10. Oh, I see. Okay. Sorry, then I should disband that room. Let me see how to do it.
Yeah, it's going to be non-existent.
Okay, room 1. Okay, I think now
Thank you so much.
okay. All right. Welcome back, everybody. Okay, I think we are all back. Okay, right. Let's have some people share their experiences doing this. I'm especially curious about how the experience is like due to the Zoom interface and how similar or different it is from the usual experience I get in a typical workshop training session. So let's have each group share this. Maybe just start with the first group and then just go down the line. Yep, somebody from group one or room one.
Hi, Prof. Yes, I can share. I
Sure.
think it's quite a fun activity, but the problem is that I think because right now we are all too stressed up as all the like deadlines are crashing. So like because I think of anxiety and everything, you can't really feel the sensations as we are supposed to.
Okay.
But nonetheless, like I think if we are doing it in a more like quieter environment, maybe with less workload, definitely this will work. Definitely. Yeah.
Sure. Thanks for sharing. I'm just imagining if let's say there's less workload, less stressful environment for everyone, then maybe we don't even need this, right?
It could enhance like our inner peace, I would say, the Zen. Yeah.
All right, sure. Thanks for sharing. Anyway,
All right. Thank
room two, group two.
Yep, I'll share.
Sure.
I think it was because I've done mindfulness before, and I think that it is just really the basics of most mindfulness things. Is more to really relax and try to get the mind off. I kind of appreciated it because like what just now the previous speaker was saying is that we are so stressed out, but I think it's a good time for me for the past like 5 minutes for me to clear my mind off. But I think it's because I'm quite tired, so actually along halfway through I kind of grew sleepy and hungry as well.
Right.
Yeah, but it was a good experience for me to really get the mind clear on that on it and just really focus on my own breathing and my own body and how it's responding. Yeah, so I kind of enjoyed it.
Sure. Thanks for sharing. I hear you say sleepy and hungry kind of sensations in the middle. So were you kind of before the start of that practice that that's kind of not so attuned to those two sensations? Maybe because you're focused on the lecture or something. Is it only during
Yeah.
the practice
So
that yeah.
so I think in a sense we didn't really think of being tired because this was really part of a routine. And
Right.
I guess it's that the day was still moving, so we don't really think so much, and somehow we are not on the
Right.
bed or
Right.
any time close to sleeping time. But now when you're getting your body to be relaxed
Right.
and really clearing your mind off, then it kind of prepares the body. Okay, it's almost time for you to rest. So that's where the feeling of the sleepiness came in,
Yep, you
and then
explained
the
it very well. Yep. Absolutely. Thanks for sharing. Indeed.
right. No worries. Thank you.
Yeah, let's move on to group three. Maybe there's no group three. Okay, group four then. Cheryl and who else? There's one more, right?
Ben. So yeah,
You joined group five. You joined Ben, is it, or something?
yeah,
Yeah. Okay.
Yes.
Ben.
Yeah. Go ahead.
Yeah. So I personally don't have sleep issues. I fall asleep very easily. I think I'm a very relaxed person in general. So when I did this exercise, I also felt sleepy.
Wow.
I can see how it can help people with who have like anxiety and like trouble sleeping because they are constantly worried. Because it will take their mind off like worrying from these issues for a while. Yeah.
It's true.
I
Even
think
3 minutes helps, right?
Yeah, even for 3 minutes it helps. I think Ben had quite an interesting experience. Maybe you can share.
Sure, Ben. You can take a minute to share anything.
I would say this type of mindfulness breathing exercise, I think it varies for people to people. For me, whenever I try to focus on my breathing, I feel very ticklish in my chest, and then it just makes me want to move around and stuff. Yeah,
Fidgety, is it? Like
it makes me very
press yourself
fidgety.
or something. Okay. Okay. Sure.
But yeah, I think it certainly is. I think it can work, but I think it depends on people to people, and also like I know some elderly people, like my own grandmother, she has like some throat issue because the phlegm always gets stuck in the throat. So I think like breathing exercise may not be the best for her, I guess. because she'll just be coughing throughout. So yeah.
Right. What if she doesn't do any breathing? I mean, just usual, go about the day. Does she cough usually?
She still coughs throughout her day, but I would say like I mean, this is just my guess lah. Like if we were to sit her down and do this sort of breathing exercise, I think she'll feel more fidgety. So
It's
yeah.
probably true. There's this saying that is not yet proven by science, which is which is similar to what Ben and what Jonathan said just now. When one start to pay attention, then you start to feel all kinds of funny things in your body, or right that you didn't know were there or is there. So like you feel itchy because we're more sensitive physically, tactile sensation, or throat itchy. There's another tactile sensation, or you realize that you have certain thoughts that you can't put aside, or you feel hungry, or you start to feel like you need to go to the toilet if you're urgent, right? Either pass motion or pass urine when you hadn't felt. So actually it arouses our sensations. This shows that you're doing it right. Your system is going into a relaxed state. The neurobiologic system and the CNS, central nervous system, is working together. And okay, I forgot to say why I say there's part that isn't proven yet. This thing that the idea that it gets worse before it gets better is not yet proven, but it's an experience of many meditators. I'm talking about non-Buddhist, non-religious, and secular, medical, clinical kind of meditation. It almost seems like a person will complain, I can't do this, I can't do that due to whatever reason. I keep scratching, I keep coughing, I keep doing this and that, and then the what do you call it? The value comes in trying to persist despite or in spite of whatever distractions. So thanks for sharing, Ben. Yeah.
All right.
Yeah. Let's move on to other persons. Group 6. Anyone? Yuvaraj or Julian or somebody from Team 6.
Yeah, I think it was quite an interesting experience. Because for me, it's my first time doing this mindfulness meditation, and I actually find it a bit distracting because like I feel like I need to focus on my body sensations. I need to focus on my breathing. Then it feels like there's a lot going on. Plus, it was quite noisy in my environment. Yeah, but I think overall, like it was quite relaxing.
Okay, sure. Thanks for sharing, Jillian. Right. Group 7. Anyone? Joy, Alison, Lingshan. Yes.
Hi, Prof. So I was the observer for my group, and according to both my group members, they felt that it was quite a good experience. I think something that we did also was we tried to play some relaxing music or some like babbling group kind of sounds, which may also help to, I guess, like speed up the relaxation of the body. Not too sure about that. But yeah.
I see. Lingshan and Joy, right, were your same group, right?
Yeah.
Maybe one of the other two could share. Or did the music help or not help? What difference did the music make?
Actually, right, I feel that the music, it made me more relaxed and like it made me feel a bit sleepy, like zoning out.
Okay.
Yeah.
Even though it's just 3 minutes or less?
Yeah.
Okay.
So like it's really calming because there's water sounds in the audio also.
Right.
Yeah.
It's true. Wow. Thanks for giving me ideas on how to do a webinar on on mindfulness practice. Yeah. Thanks for sharing, Group 7. Let's move to Group 8. Who is in Group 8? Roshi or Pearl? Yep. Go ahead.
So like when the person was reading, like she was reading out like the different body parts to relax, I found that like there were other body parts that I was still very tense and wasn't loosed enough. So as she read, like, so it wasn't that bad, the experience wasn't that bad because it brought attention to that body part, and so I was able to loosen the muscle there.
Right.
And also I guess another psychological aspect that I realized, because I read it somewhere, that like making your mind empty when you're trying to sleep actually makes you less able to sleep because your brain is trying to fire up more
like imaginations and pictures in your mind, but having something to focus on, like one image to focus on, which is like the body part, helps. It's like only actively firing like one pathway in the brain, so it like makes you focus on that part and like makes you fall asleep better. And like I've been using this technique, which is like imagining, like picturing one scene or something,
Yes.
which helps me to sleep. Yeah.
Absolutely, and that has been shown scientifically already. And the one scene could really be any simple thing that anyone is familiar with, or it could just even be the number one, or a color, or an alphabet. And because like Pearl, like you said, why it doesn't work, the so-called clearing your mind, is because the human mind doesn't work that way. It's counter to the mechanisms of our human cognition. Right, our cognition is built or designed in a way where we could focus on one or two or a few things, right? But we cannot focus on nothing or everything. We just cannot. Unless you're unconscious, then you can. Well, there's nothing to begin with, right? So the minimum is one, and when one is focused on one thing, right, to the exclusion of others, then yeah, that's when the experience of relaxation is felt, and that has been shown scientifically. Thanks for sharing that. That means you also went into that state. You must be quite a seasoned or somewhat seasoned practitioner, I guess.
Yeah, that's how I do it when I sleep. Yeah.
Thanks for sharing.
Yeah.
Right, group 9, Ansheng and who is Rishan, Chloe. Yep. Anyone want to share group 9?
Yeah, so I didn't really experience like trance or any of that very deep stuff,
Okay.
but I was able to experience the sensations in more detail than I would normally pay attention to them.
Mm-hmm.
And to be honest, it didn't really make me more relaxed.
Okay.
So yeah, it made me fixate on each like sensation more.
Oh, sure. Could you give an example? Like you said, fixate.
Like
what is one of these?
one of the instructions is focus on your feet,
Yeah.
right, or
Yeah.
something.
Yeah. So
And,
you actually
yeah.
imagine your feet. Is that what you mean?
No, like I was like hyper focusing on the feet, like pressing on the ground,
Right.
instead of being more relaxed about the feet pressing
I
on the ground.
see. Wow. Okay. I see. Sure. Thanks for. Is this your first, or are you a seasoned practitioner?
No, I'm not seasoned practitioner.
Okay, sure. That's okay. Novice, I mean, beginners do often feel have different things, and it may not work for all beginners the first or even second times, the initial times. But yeah, to elicit that kind of relaxation or desire and relaxation. Although I should also qualify that by saying that our personal individual expectation of the quality of the nature of the relaxation also plays a part. That means what is relaxation to me may not be that to you or to her or to him, may be different, and my expectation of that plays a part in my actual experience of that. Yeah, think of it as the either the placebo effect or the nocebo effect. Yeah. Thanks for sharing.
Okay.
Yeah. Let's move on. Team 10, is there a group 10? Yes. Alexis.
So
Who were with?
I was with group 1.
No worries. You can share too.
Okay. So I guess personally, I felt like it was not bad, but I think it was quite funny because nearing the end of the script, I guess, like when there were no more instructions to be given, then I sort of like lost that state of like feeling very relaxed. Then suddenly I just started thinking of workload. Then it kind of ruined everything. So it worked temporarily, I guess. Yeah.
Wow. I'm thank you for your honesty. When it's gone.
Yeah, like when the instructions finished, and then it ended.
When you fixated, or when you waiting for, okay, I don't know whoever was sharing, but when you hoping to hear the voice of whoever was reading the script at that point.
I guess like
okay.
Oh, it's like, was I waiting for more instructions?
Yeah, were you waiting for like, okay, is he gonna talk more or she gonna say the next word? Are you having those thoughts like that? What's the next word or he or she is gonna say?
I guess, yeah, there's the anticipation for more instructions.
Okay.
Since like you're slowly entering that state of like feeling relaxed as the instructions go on. Like you get more and more relaxed, then suddenly you just stop. Then I was like, oh no, it
I
stopped.
see.
Yeah.
I see. Okay. Sure. Well, yeah, I didn't want to increase the complexity of the script, and because many of you probably realize you took less than 3 minutes to finish that script. Part of the exercise, thanks for sharing, Alexis. Part of the exercise actually
No
is
problem.
get us to perhaps even do it twice, but I guess in a lecture like that, no time for that, because the second time, then that's when we try to correct one or more of the mistakes or observations that we see ourselves or see our teammate or partners have, right, in order to improve those, improve the reading and or the personal experience of the relaxation. Yeah, so that is when then I teach the class, or the workshop participants, how to get one back to reality or back to so-called conscious state. So many of us might have closed our eyes, kind of slump a bit. Whether or not you feel relaxation differs, but you more or less are in some different state or mental state or emotional state. And then how to come back, right? Sometimes if the coming back is too abrupt, then you get a shock, and then the shock is enough to eradicate all the relaxation you feel. Sometimes that occurs. Sometimes when you don't come back long enough, then you are lost, and then you worry. So then the worry, or once again could be more salient. It becomes a deeper or more intense feeling than any semblance of relaxation that one feels. So the coming back, the going in, are also moments. That the human mind and body plays a part. Thanks for sharing, Alexis. So 11.
For our group, only 2%. Then I know it's supposed to be like a 3-minute long thing, but then because both of us only take less than 1.5 minutes each, so we ended before 3 minutes before you come in, right? And yeah, I think the experience was not bad. Like we both felt relaxed and like refreshed, but then like I feel like maybe we could have talked a bit slower, like increasing the time. Yeah.
Sure. I took about a month to learn to speak slowly. In my initial days, my first job post graduation from undergraduate was actually a counselor, and from something like, what was the script? Let me just take one line from the script. Okay, so let's say the first line, right? You can close your eyes if that's comfortable for you, right? That's my usual speed, right? It took me a month to learn to say you could close your eyes if that's comfortable for you. Right. So you could tell my rising and falling inflection. Yes, like kind of loud and then soft and loud and then soft. And you could kind of tell that the words, you may not hear clearly every single syllable articulated, but you could still kind of make out what it means and for. Yeah, so it just takes practice. But I'm glad you realize this, and I'm sure within a week you can get this, and you can lengthen a 3-minute script like this to a 6-minute. So eventually, now I can do a 3-minute in I don't know, maybe 15 minutes or something. Really slow and long pauses, and I won't feel one of the things I also learned is that I don't feel uncomfortable. A lot of times I, being the reader or the leader, feel uncomfortable while that person is already somewhat relaxed or quite relaxed, and I just need to move on because silence is often overwhelming to me because I'm awake. I don't know if any one of you feel that as you are the reader, yeah. Hui Ming, are you sharing something?
No, thank you.
Okay. Oh, Cheryl said yes. Okay, right. Thanks for saying yes, Cheryl. Yeah. So I also part of doing this mindfulness meditation. I think as the leader, even as the meditator, I learned that one has somewhat got to learn to. I mean, not say got to learn. There's value in learning to accept silence, to value silence, and to appreciate silence for what it is, silence, and it's okay to be silent for 1 second, 2 seconds, 3 seconds, even when there's a person. Yep, even if that person is a stranger or your patient or your friend just sitting by you or in front of you, and it's okay. And many times it's not okay, right? In a typical social setting, I think that is right something that we I think this exercise teaches us. Thanks for sharing. And number 12, team 12. Anyone? Perlin or yep, or yep. Go ahead.
So there were 3 of us. So we took like each row and did the thing for 3 times. As an observer, I think we couldn't really observe anything because like we're in a screen, yeah.
Okay.
And then as a reader, I think something that we were unfamiliar with were like about the pace. Like we tried to read it slowly, but I'm not sure how long we take. But I think the silence part was something that, yeah, like you kind of want to stop and pause for a while, but then you don't really want it to be silent. Yeah, and then as the listener, I think most of us felt relaxed during that 3 minutes. I think for me, like mindfulness, this kind of short mindfulness exercise is something that I've always wanted to try, but then I didn't really get to. And then I think after this experience, I think I would probably like do this kind of exercise more regularly. Yeah. I think it's a good thing to have because like I think in the past few weeks we were quite busy. So even if we have some time, we won't really sit down and think about things or relax. We will like go and find other things to do. Yeah. So I think it's a good exercise to do.
Thanks for sharing, Yan Chong. I'm just curious for group 12, right? Yan Chong and Perlin and who is the other? Qi Yun, right? Were any of you kind of mindful of or conscious of the time when you were the reader? I mean, when you're reading the script, I mean, as you read, you're also thinking, okay, how much have I taken, or how much time is left? How much? Did any of you notice that thought? Anyone?
I have
already. Yeah, go ahead.
Because like I also don't want to be reading too quickly. So like I found myself deliberately slowing down lah. I mean, it wasn't so much on how much time I've taken, but more of like I don't want the whole process to end too quickly because I read it too fast.
I see. Sure. And Perlin, are you a seasoned meditator or is your first time you're doing this?
First time.
First time, right? Sure. Thank you for being conscientious. That's the C part of your personality, I think, that is helping you on that part. Yeah, so when I was a novice, a beginner, I realized I kind of tried to do the same thing. I'm mindful of the time. In fact, the word 3 minutes actually already primed my thoughts. That means I'm supposed to do this in about 3 minutes, not too fast. So when I'm halfway through and realize I'm already 30 seconds. Halfway through, I spent only 30 seconds. Means I have 2.5 minutes to complete the rest. I had a short panic just for, like a little bit of, you can say, well, not panic, maybe fear or nervousness. And because the instructor was just in the room, right, somewhere nearby. So everyone is still doing it slowly. I realized I'm about to stop, So then I realized even that thought, right, it can be good or bad. I mean, it can either lead me to go much slower, or it can actually lead me to go faster and finish off. So I realized that just framing this 3 minute thing, right, for new people, for some of us might help, right? For others, it may not, or it may help only midway, right? But certainly, I guess with experience, with practice, the word 3 minute, 5 minute, you don't need that. All you need is a script. In fact, with experience, you can make up your script just like that. So scripts could be spontaneously made up and talked through by an experienced practitioner dealing with or helping or managing a person with various physical/mental/sleep problems, tailoring the script to his or her conditions, perhaps even work-related issues, relationship problems, anything that cause acute stress, right? Recall the precipitating event, in the middle of predisposing factor and perpetuating factor. So those two are not the target audience of mindfulness. The target audience of mindfulness practice is the acute. Right? It is kind of to de-intensify, de-escalate the acute, and so that the person, you can say, is clearer mind, more relaxed state, right, more able to talk with the therapist or the counselor or the doctor or psychiatrist, right, better in a more facilitative and more collaborative way on those predisposing and perpetuating factors. So one, if he's so uptight, so worried, or so angry about not being able to sleep, right, person is not going to be able to talk much to you, to the helper, whoever is helping him or her, about all the other things that you need to know in order to help him for the longer term. So MBSR, or mindfulness-based stress reduction, certainly is very applicable in many settings, in many contexts, with a variety of persons, and to manage a variety of conditions. Okay, thank you for all the sharings. I'm so glad that many of you found that useful, either personally or at least a skill that you could learn, and I hope you could even you could even share with your family and people around you, and in fact it could be implemented or practiced even right after this lecture, like even tonight when you go to bed, if that helps. So I think I should just share my last slide, and that will be the end of the lecture content proper. Let me do a share screen. Share screen. Okay, here we go. So this is what is this? This essentially shows the various barriers that are commonly faced by persons, beginners of mindfulness, who practice mindfulness meditation. I feel bored, the voice is too soft or too slow, I feel nervous or anxious, when is he going to stop, when am I going to go for my meal, I'm hungry, right? Or I feel angry that this thing he or she still keeps going on non-stop, and my sleep problem not solved. I'm doubtful whether it helps. I feel sad, I'm helpless, hopeless, I feel sleepy, I'm going to sleep, I can't concentrate on his voice, right? Or I just feel uncomfortable, right, physically in various ways, pain here, itchy there, throat dry, whatever. So these are the various barriers, and the way we seasoned practitioners learn to deal with this is to say, look, these barriers, we can come back to them later. That means my discomfort might still be there after the mindfulness practice, my feelings of sadness, loneliness, my anger, my boredom, etc. I can come out to these thoughts and even act on them later. But for now, right, let me kind of come back to the focus, which is, says, this part of my body. So the idea is temporarily put aside these thoughts or distractions or barriers, mentally put them aside, then refocus on the object of focus, and then keep repeating this process. Put aside, refocus, put aside, refocus, put aside, refocus. And with repeated trials, repeated practices, medical science has shown that, well, this works. The putting aside, refocusing, the mental mechanism involved in doing this repeatedly, putting aside, refocus, actually gives rise to the physiological and measurable physiological outcomes of relaxation, which essentially are reflected in those biofeedback monitors, like lower heart rate, lower pulse rate, lower blood pressure, lower body temperature, and so on. Okay, I think that's the last slide. Yeah, I think that's the last slide.